Hey, Clay Smith, Journal Feed. I am so excited to bring you 4 articles that I think were some of the most important articles that had to do with Airway in the past year or so. So I initially presented this as a grand rounds for the Kaiser Permanente group in San Francisco, and now I'm modifying it to bring it to you here on the YouTubes. Here is a list of the articles that we are going to cover in the next 10 to 15 minutes. So buckle up, let's get started. First up, the Bougie randomized controlled trial. Is this Bougie? Anyway, the BEAM trial was a single center study based in Hennepin County that found there was first pass success greater in the Bougie first group as opposed to the usual endotracheal tube and stylet. Now, when you roll this out in this Bougie randomized controlled trial, they did it multi-center ED and ICU based and found that first pass success was actually a little bit lower in the Bougie group, though that was not statistically significantly lower. So what this tells me is that, hey, in Hennepin County, this is what they're best at. This is the way they train. They're really good at a Bougie first approach. And so if you are good at that, do it. If you usually use a stylet in your endotracheal tube as a first go-to, do that. So this tells me that at scale, a Bougie first approach doesn't have a lot of legs. So do whichever one that you feel the most comfortable with because they're both about the same. So that gets a reasonable rating on my spoon feedometer. The next study was done in 2022. It's actually guidelines from the anesthesiologists. And so this was important, but it's way too much to cover here. I covered this on the journalfeed.org blog in depth. You can see everything that the anesthesiologists thought we need to know. And I really break it down for you as emergency physicians about what you need to know out of these guidelines. In addition, as a freebie, there is some more information about awake intubation and some techniques, tips, and tricks that I learned from both this article and from other sources like MCRIT and Canadium. Thank you guys. So definitely read this, but it's too much to cover here. This gets a recommend on my spoon feedometer. Next is the MaxEyes ICU study. It was a study looking retrospectively at multiple French ICUs, and it was direct laryngoscopy based, not video. And they found that a MAC 3 had higher first pass success rate than a MAC 4, which is kind of counterintuitive because a lot of times my go-to blade is a MAC 4, and yours might be as well. So this is interesting. It is hypothesis generating. Should it be practice changing? Maybe not yet, but I have been reaching more for the MAC 3 first. This is always subject to potential confounders. Maybe MAC 3 first patients are those who have easier airways, and so there's a confounder there that we can't account for in a retrospective study. Could be. But consider, might a MAC 3 be a good go-to blade? So this gets a maybe on my spoon feedometer here. Finally, the Near for Kids video laryngoscopy study found that VL is great for kids. Now, the Viper Collaborative was a video-based study in the past, and they said, well, VL is no better than DL. But what they considered VL was if the intubator only looked at the screen. They only looked indirectly at the screen. If they looked at the airway, they called that DL, which is like, what? Anyway, so in the Near for Kids registry, it was multi-center, 11 sites, 1,412 patients, and they considered video-assisted laryngoscopy versus DL. So video-assisted could be you use a video scope, you maybe look directly at the airway, maybe you look at the screen, maybe you do both. If you were using a video scope, they counted it as VL, and they did find increased first pass success. Not a little bit, a lot. The odds of first pass success, 101% greater with video laryngoscopy, video assisted laryngoscopy versus DL. And they also found that adverse events were lower. Now, that was not statistically significant, but severe adverse event rates were statistically significantly lower, and I think clinically significantly lower. So I think VL is probably best for kids. That gets a maybe. I want to close with this. Is it a coincidence that DL stands for direct laryngoscopy and driver's license? Because I have taught all my kids how to drive, except for my 14-year-old, but I've taught all the other ones. And it is so nerve-wracking. It's the same kind of nerve-wracking that I get when I'm watching a new resident learn to intubate with direct laryngoscopy, which I don't use anymore. VL is so much more peaceful for me. But anyway, DL, coincidence? I think not. Anyhow, that's what I got for you on Airway articles. And if you like this, you will want more of it. Go to journalfeed.org where you can subscribe to our newsletter and get these posts delivered to your inbox every single weekday morning at 5 a.m. Central. You can get full blog access as well as the full podcast. I'm just saying, it's a great deal. You're going to want to do it. So with that, I'll sign off. Journalfeed.org where you can read less, learn more, and save lives. See ya.